I'd like to welcome you to our ECHO session today on trauma-informed care and cultural safety. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original peoples in now what we know now as Canada. We are grateful to have the opportunity to present in this territory. And briefly, I'll go over the Palliative Care ECHO Project with you, which is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. We invite you to stay connected with us and keep in touch, of course, via our website at www.echopalliative.com. The Palliative Care ECHO Project is supported by a financial contribution from Health Canada. Therefore, the views expressed here do not necessarily represent the views of Health Canada. Many of you might know Pallium for our LEAP courses and our LEAP content. LEAP Core, which is predominantly one of our most popular courses, it is an interprofessional course that focuses on the essential competencies to provide a palliative care approach. It can be delivered online or in person. And of course, it is ideal for any healthcare professional. So whether you're a physician, a nurse, a pharmacist, you are more than welcome to join, and it is accredited by the CFBC and the Royal College. I would like to introduce myself. My name is Diana Vince. I am the Palliative Care ECHO Project Manager at Pallium Canada. I will hand it over briefly to our presenter to introduce himself. Go ahead.
That must be me.
Yes, yes, it is.
Thanks, Diana. I'll incorporate some of my introduction into the presentation, but my name is Rami Shami. I'm a hospice palliative care consultant. I'm very privileged and honored to be a hospice palliative care consultant, especially with the 35 years I've had the privilege of serving in this field. But I'm also privileged to be at Kensington Health as a case manager focused on caregiver support and bereavement support. And I work for an esteemed organization called Lighthouse for Grieving Children, where I provide some of the community advisorship.
Thank you so much. Welcome, Rami. We are more than happy to have you. And I'll go over briefly the conflict of interests. So for Pallium Canada, we are a non-for-profit organization, as mentioned before, partially funded by Health Canada, and we do generate funds to support operations along with research from course registration fees and the sales of the Pallium pocketbook. I myself, along with the presenter, have nothing to disclose, as you see on this slide. And the Scientific Planning Committee, so therefore the presenter that is with us here today, had complete independent control over the development of everything that you will see in front of you. A few brief reminders before I hand it over to Rami. So for comments and introductions, and I do see that the chat is very, very movemented. So thank you so much, everybody, for taking the time to introduce yourselves. It's fantastic. We do ask that for any questions that you may have, please use the Q&A function. So do not put your questions into the chat. It might be very difficult for us to keep track of it given the large number of people that we have in our group today. So please use the Q&A. And of course, we will answer, questions will be answered as we move along throughout the presentation. And there will be a Q&A period at the end of the presentation. The session is being recorded, so this recording and slide deck, of course, will be emailed to registrants within the next week or so, and you'll also be able to find it on the ECHO website. So without further ado, I'll pass it along to Rami for the rest of the presentation.
Well, thank you, Diana. Thank you so much. This is exciting, folks. I hope you all can hear me okay, because I was presenting a few months ago and halfway through the presentation, and it was national, halfway through the presentation, somebody actually had the kindness to tell me that they couldn't hear me, but I have a fancy dancy mic, and I'm really excited to share this passion of this subject with you all. I want to make it a little bit interactive. I see people from across the country, which is incredible because hospice is oftentimes a small community with a great reach. And I want to keep it interactive as much as possible. We only have less than an hour. I'm basically scratching the scratch of the scratch of the surface to what I'm going to share with you today. So if it's quick and it's a lot of information and what have you, all in a very short period of time, we're lucky we have a recording. I just want to share so much with you, especially what I've learned in my years in hospice palliative care, that we're condensing probably a 3 to 4 hour presentation into less than an hour. So we'll try to keep it as engaging as possible. Please throw up your comments. Thank you, Andra. I appreciate that. Throw up your questions or comments. I might just throw some things out there if we could, you know, dance around a few of these subjects as we carry on. And I also want to just do a quick shout out to my esteemed colleagues, Evelyn and Teresa here at Kensington Health. So I'm excited to have you with us. So let's get started. This session, folks, is trauma-informed care with a focus on culture humility and a definition of culture safety. Because I don't as much speak to culture safety. That's not more for my forte. I feel that's a topic all in itself. But culture humility is the subject of culture humility, if you haven't heard of it, is grounds trauma-informed care, and it grounds anti-racism and anti-oppression, where we focus on personal culture. We focus on the individuality of the personality of culture within the greater context of who and what we are. So let's rock and roll. I don't know if anybody recognizes this geography, but this is Southern Ontario. This is predominantly where I work, although I've had the privilege of working pretty much all over the place. This is predominantly where I work. And I feel this is reflective of the communities we have across the country. But because this is where I work and apply my craft, I find, and you can see the snow is on this picture. This is the Great Lakes, folks. And down in the right-hand side is where I live and work. Because it's going to snow anytime, right, in Southern Ontario. But why I appreciate working and living in Southern Ontario, especially in this regard, is because it is in many ways the most diverse demographics of people in the world. And in many ways, it mirrors communities across Canada. Canada is so incredibly diverse, however you define diversity, whether it's social economic background, color of skin, food, ethnicity, however you define culture, gender, sexual orientation, sexual identity. We have it all. Indigenous nations, Indigenous peoples, we have it all here in Canada, and for me, especially in Southern Ontario. So in my mind, if there's a model of engagement that can work and be and as a program provision, work and be accessible to the populations we have in one of the most diverse demographics of people in the world, then there must be some kind of traction and efficacy to that model of engagement. And those model of engagements are trauma-informed care and culture humility. If I may, folks, I don't think we can talk about traumatization, especially what's happening in the world and today. But I don't think we can talk about traumatization without acknowledging, at least for me, folks, I speak from myself, acknowledging the land that I am living and standing on here today in reflection to my parents coming as immigrants and refugees, not recognizing the trauma, the harm, the blood, the genocide that's been incurred by Indigenous peoples for millennia, for me to be standing and working and speaking with you today. So I would like to acknowledge the land that I'm standing on today is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge Toronto is covered by Treaty 13 signed with the Mississaugas of the Credit and the Williams Treaty signed with the multiple Mississaugas and Chippewa bands. And if you don't know where Toronto is a little town just on the tip of Lake Ontario. And we have an incredible hospice palliative care programs here that I have a lot of fun working with in terms of the catchments. So what are we going to do today in a short period of time? We're going to contextualize trauma and traumatization, not just necessarily within the PSW role, but within the clinical role, if not even the volunteer role, even the social work role, the psychotherapist role, the nursing role, if not the physician role. We're going to learn briefly how to apply a trauma-informed care, because it's a very simple approach, folks. I love specifically, respectfully, I love teaching this even to volunteers. I'm actually teaching it this evening at Victim Services of Toronto, because when we speak about this principle that's so applicable and does not necessarily mean we're doing trauma therapy. It's a simple approach that can be applied by anybody within the field of caregiving. And then we'll speak a little bit to culture humility. What is it? How do we apply it? What's the grounding force in it? And how does it interface, if not intersect, with trauma and trauma-informed care? And with any presentation, when we're talking about trauma, traumatization, folks, please just be mindful that it can arise experiences for us, feelings for us. I've experienced a lot of childhood developmental trauma. My parents were from war-torn countries. They come here as refugees and immigrants. They experience a lot of PTSD or PTSS, as they call it now. So you had a name like Rami, Shami, and my childhood was anything but easy. But I just want to be mindful. If something arises for you, you're welcome to take a break. You're welcome to stop. You're welcome to turn away. You're welcome to seek support. Because when we talk about traumatization, especially as it's somaticized in our bodies, you have to be always mindful what stirs from us in the subject matter. And also, just a disclaimer, folks. I'm not a therapist. I'm not a social worker. I'm not a physician. I'm not a clinician. I'm actually somebody with a university degree that's just been in the field for a very long time. So what I bring for you is stuff that I've succussed and diluted in the field. And I've learned much of it on my own, in my own learning, and applied it and worked with it and seen what works, what doesn't work within the diversity and demographics of people that we serve. And then I have this wonderful opportunity to share it with you. That's me, folks. A very long, a long time ago. I know I haven't changed much. I just grew a beard over COVID, but I don't know if anybody recognizes this amazing lady. And I put this picture up because in that particular moment when I met this person, if anybody knows who it is, please put it up in the questions and answers, because it is a question. In that particular moment, this incredible woman, I felt, held me in such an embrace that she somehow saw all of me. And what is trauma-informed care? One of the most diversifying aspects of our being that's often missed when we talk about diversity is trauma. The individual expression and experience of traumatization, in my mind, is the most diversifying aspect of our being. No, Josephine, it's not Dame Cicely Saunders. Good guess, though. But thank you, June. It's actually Miss June Callwood, the late Miss June Callwood. And what I felt that she held in that embrace, she kind of felt or held my entire embrace. And so often in hospice palliative care, what we miss, folks, is the fact that this entirety of the person, the whole person, and not necessarily to know about their experiences of traumatization, but recognize the expressions and behaviors as caused and precipitated by traumatization that we miss. And in that moment, I felt like I was the only person in the world that she was paying attention to me. And it only lasts 15, 20 seconds, maybe 30 seconds, as she made fun of my unibrow and my name. But there was a feeling. I said, I want more of that. I want that groundedness, that she's holding me in that sense of presence. And I've literally, that echo of that experience, without a word of exaggeration, has defined my career over the years. Yes, it's Mr. If anybody doesn't know who Miss June Callwood is, she established 50 social service organizations across Canada, and she's most famous is Casey House, what was an AIDS hospice here in Toronto, named after her son, Casey House, who was killed by a drunk driver when he was 17 years old. So, folks, in 35 years, I can't believe it's been 35 years, Evelyn. In 35 years, I've seen a lot of death. I've seen a lot of trauma. I've seen a lot of grief. I've seen a lot of celebration of life and joy and laughter and joking. But what I've seen the most is this change in who and what we're serving. Who and what we're serving is becoming more and more diverse. More and more aspects of diversity are coming to be served in our field. In my field, specifically in hospice palliative care. And not only is it the catchment of peoples that are coming to be served that are becoming more and more diverse, however we define diversity, it's who's serving them. You know, if you can imagine 35 years ago when I started as a hospice volunteer, providing, in-home support, what that demographic of peoples was in the training that I did. And also, folks, when we talk about diversity, as we expand services to serve, to encompass people who are receiving services in hospice palliative care, we're starting to become more accessible and inclusive of who and what they are and where they are. And that's where trauma comes in. So often people experiencing trauma or traumatization were marginalized or even excluded from hospice palliative care services. Many of you know about harm reduction, right? And often between 80 and 90%, I would say approximately, of people who use substances problematic substance use is to cope with traumatization. And most of our hospice palliative care programs are not harm reduction models. And in that way, we are denying people who have experienced traumatization their coping mechanisms with which to receive hospice palliative care services. So we are not completely accessible and inclusive in that regard. And that's where trauma and traumatization, the awareness of it, not necessarily the understanding, but the awareness of it starts to take root. Folks, I got the greatest job in the world. I mean, I love I'm trying not to swear. In hospice, we swear a lot. I love the crap of what I do, right? Above the fact that I'm a consultant, so I get to learn a lot and share a lot in knowledge sharing. I work as a case manager at Kensington Health, so I provide caregiver support in our hospice, in our long-term care, and in the community. But I also provide bereavement support for those who, for people who have experienced a death at our hospice, sometimes even in long-term care, and definitely in our community. So I got a big job. And then at Lighthouse, I provide all of the community advisorship, the diversity, equity, inclusivity aspects, the culture, humility, and I run a really cool podcast for them, all from a diversity lens. And why I like showing this, folks, is that if this model of engagement called trauma-informed care can work in our 19 bed, correct? We used to have 10 beds, 19 bed hospice residence, and it could work in our long-term care facility, and it could work in our community, wherever I serve in the community, from people's homes or however we define a home, underneath bridges, on the streets, in community centers, and it works for grieving children in a peer support group setting. If it works in those, then we know we have something that's accessible and inclusive. And I know I started off with that, but that's a really important point, because that's where you take a program or a model of engagement and you try it out in all these different settings to see if there's an inclusivity and accessibility to that program. And that's trauma-informed care. And folks, it's interesting. I was just talking to one of my closest friends earlier on this morning, and he has COVID. And it's not like we're obviously done from COVID. But what I wanted to show with this is that COVID-19 in and of itself has literally left a traumatizing aspect on the entire world. We're going to see the impact of this invisible threat. I mean, if that's what you think, I mean, most people in healthcare respect that fact, because there's others that don't necessarily abide by the whole COVID thing. If there's this invisible threat that has traumatized us, perceptively or physically threatened our well-being for the past 3 years and continues to do so, that has left an imprint of an hyperarousal within our nervous systems to constantly be on guard and aware. In essence, I feel the entire world is living in some form of a traumatized state, if not an exacerbated traumatized state, with all the implications of other aspects of traumatization. That's left our fight or flight and our hyperarousal on alert. And that's what we live with every day. And that's what we go to work with every day. And I think to myself, I've worked in healthcare for over 30 years. I think to myself, if you look at the implications and impact of COVID-19 that many of us have experienced frontline. I mean, I was on the front line during the COVID-19 pandemic, as if it's over. But then you add the intergenerational aspects of traumatization. You look at indigenous peoples, the intergenerational trauma they've experienced. You look at my people and the traumatization I've experienced from my parents and their foreparents coming from war-torn countries, and that I'm hoping not to pass down to my kid. But trauma, as you might know, can be transmitted through DNA. So it's not as if I can even help it. If we look at the intellectual and developmental disabilities and challenges of traumatization experienced by such individuals, if we look at the impact of racism, my childhood was full of racism in that regard. If we look at the implications of being traumatized through even just expressing our gender, our identity, or the impact of colonialism, which we feel to this day. If we look at child maltreatment, such as my child abuse, such as my upbringing, or domestic violence, which is at an all-time high during COVID-19. If we look at war, look at the war that's happening in Israel and in the West Bank and Gaza. And if you look at Ukraine and Azerbaijan and Armenia, and what we see all the time on media. If you look at the implications of school and commuters, my kids' class last year in 2 weeks was, quiet holiday week, was shut down and locked down 4 times as a result of knife and gun violence in the environment. We look at medical trauma. Last October, I almost died. Not this October. Last October, I almost died as a complication of Crohn's and bowel obstruction. So I have this living medical trauma that I'm working through. We look at aspects of homelessness and vulnerable housing. We don't address people by their housing situation. We don't call them the homeless, we call them experiencing homelessness or vulnerable housing. We look at the impact of Me Too and sexual assault and sexual violence, or even accidents. I mean, I was biking this morning and I fell off my bike, right? Or the impact of immigration and refugees, which we see across Canada. And if that isn't all enough, folks, we have climate change that's literally threatening, if not perceptibly, mentally and emotionally, our futures and our children's futures. Folks, if this is all happening to us, and these are all implications of traumatization, then why are we not talking more about trauma and healthcare? Why aren't we talking more about trauma-informed care in my field of hospice palliative care? Because this is literally us serving us. And that's why I think it's extremely important for us to talk about trauma-informed principles as a result of all that we're experiencing today. Sorry, I get very excited about this stuff because it's so clear to me and so clear to somebody that I've studied with, Dr. Peter Levine. He says trauma is perhaps the most avoided, ignored, belittled, denied, misunderstood, and untreated causes of human suffering. And folks, when we talk about suffering, it's a little bit different from pain, or it can be different from pain. No? Do you agree or do you not agree? And so if we're talking about suffering that can perpetuate and cause physical pain, and we're not paying attention to trauma that's causing the suffering that's precipitating into physical pain, then what are we doing? How is that truly person-centered care? And so Dr. Peter Levine had it right in that regard. So let me ask you quickly, if you put in trauma into Netflix, and you put into Prime, or even put it into Google, right? Dr. Google, what comes up for you, do you think? Just quickly, what do you think, folks? What's the definition of trauma do you think is applicable? What are your thoughts? We have a lot of people on the line. We have 200 people in line, so we should have a few answers out there if you don't mind engaging. How do you define trauma? Because I know when I put trauma into Netflix or Prime or even Google, it comes up as guns and violence and murder and stabbings and 911 and what comes up for you? Yes, Kaya, I hope I say your name correctly. Injury, damage, a blow to the brain, soldiers. Yes, what else? Oh, I haven't seen that, Giselle. The next, I got to check that out. Beef, unrelenting stress. Thank you. You see what Kelly just said, folks? What's so important is unrelenting stress. What we miss in Gabor Mate, no doubt, Leanne. Absolutely. Joan says, inability to respond. Well said. Physical, mental injury, response to unease, a little bit more than unease. Okay. What else we got, folks? Physical, mental, emotional, spiritual injury. Yep, for sure. But I want to go back to something. Keep them coming, folks. Dr. Gabor Mate just released an amazing book called The Myth of Norma. I love it. Feeling unsafe, loss of loved ones. Well said, folks. But I want to go back to something that Kelly Miller said. She said, unrelenting stress. See, what often happens with trauma and traumatization is that it's thought to be acute. It's thought to be sudden. It's thought to be one-time shot. And it's not, folks. Many of you are saying physical and mental suffering, but what Kelly's saying in unrelenting stress is that it could be not just one incident. It could be a cumulative cascade of incidents over 30 or 40 years, like the work that we do, like what we do in death care. The constant micro dosing of these, somewhat traumatizing experiences, but it's not traumatizing necessarily in their singular, they're traumatizing in their accumulative, right? Folks, respectfully, and some of the great work by Dr. Gabor Mate and Dr. Peter Levine and what have you, most of traumatization is that accumulation. Most of the traumatization isn't acute. Most of it is actually almost subversive or subconscious in how we experience it. Minnie says it's the lasting emotional response that results through distressing event. Let's check on that, Minnie. I'm gonna challenge that a little bit because I think it's a little bit more than emotional. Now, I think maybe I don't know if you read it from the CAMH definition. Okay. This is the CAMH definition from their website. They might have changed it most recently, but I just want to challenge this just a little bit, folks. It says, the CAMH definition is trauma is a lasting emotional response that often results from living through a distressing event. And that's what Minnie's saying. But let's challenge that just for a minute. Is trauma always emotional? Right? Joan says most trauma is subconscious, subacute, ongoing. Yeah, absolutely, Joan. I couldn't agree more. Is trauma emotional? Trauma could be physical. Do you know if trauma experiences of traumatization can actually go straight into the body and not even be registered in the mind? Trauma is more than emotional. Trauma is physical, psychological, mental, psychosocial, existential, spiritual, right? And Joan says somatic, for sure. So let's change that, because it's not just emotional. All right. That's why even being in the presence of an experience can cause us to experience traumatization on a physical level. And it's not necessarily lasting. There's some great work that's been done that, through addressing traumatization, that it's not necessarily lasting. It can be healed. It can be modulated. And often the other thing is that, is it really you living through the distressing event that causes traumatization, or is it you listening to somebody else living through the distressing event? That's Dr. Bruce Perry wrote an amazing book called The Boy That Was Raised as a Dog, which is really the story of my life, right? And in it, he says, somebody who's listening to somebody else tell their experience of racism or homophobia to someone else can be just as traumatized as the person who's experienced it directly. So we don't have to necessarily live through the traumatizing experience. Alana says, can be listening, watching, hearing distressing events. Absolutely. The news these days is traumatizing. I couldn't agree more, Alana, right? And folks, did you notice that the distressing event is singular? Does it necessarily need to be singular? Or can it be, yes, Krista, generational trauma? It actually can be, and we'll get to vicarious trauma, hopefully, Kelly. It can be actually a cascade or multiple events that microdose in their accumulation and their collective that become traumatizing. That's what we miss. And by the time that it's traumatizing as that accumulation of microdosing of those experiences, we call it burnout. But we don't see the microdosing over time of those experiences of events that accumulate in traumatization, right? And that's what we see often in hospice palliative care. Thank you, Courtney. Complex developmental trauma. I can't get it too much in trauma. I'm not a therapist, folks. I'm going to stick with trauma-informed principles because that's what I can speak to, and that's what I like to speak to, especially as a diehard volunteer from 35 years ago. I can apply it. Now, let's just demystify some of the languaging. All right, folks. Trauma is the event. Trauma is not something that you have. Often you hear people say, I have trauma. That's not quite correct. Trauma is the event. How we respond and receive and react to the event, that's traumatization. We can somewhat say I have traumatization, but it's more the fact that it's our response and reaction and experience of a traumatizing event that is the accurate languaging. So what is a traumatic event? What could it be a trauma? I heard some of you, many of you, I think even Huda said it. Being born in this world is already a trauma. Huda, that's not far from the truth. The actual birthing process can be experienced as a traumatization. That's why oftentimes, if you look at how trauma is healed and navigated, the crying, the screaming of a newborn baby is part of the dissipation of the potential of it becoming traumatizing. All right, that's actually an excellent point, in that regard. But I think you were meaning it in a different way. But I agree with you. I mean, everything that's happened to us. You saw the list. Anyways, a traumatic event. I heard some of you say this. One that can leave a person feeling overwhelmed. It could be the situation is perceived as threatening. It doesn't necessarily have to be, physically threatened. It's our perception of it. And that's why in hospice palliative care, that's so important, because so often we're kind and compassionate and we want to care. And yet the person we're caring for perceives us as a threat. What's important is that their perception of us is what dictates how we care for them, because they perceive us as threatening. It's the perception that's important. And the perception is that individual piece. And then it leaves a person feeling out of control, helpless, unable to assimilate or integrate events. Sometimes we end up compartmentalizing or dissociating from the experience in order just to survive it. Okay. And it could be an event or events that overwhelms a person's ability to cope. And so often that's what we see surfacing when we're caring for people receiving a palliative approach. For me, folks, as I've come to understand it and become aware of it, especially within my own body and my heart, I think a lot of my Crohn's and bowel obstructions are from childhood developmental trauma. I can feel it down there. That's my barometer. That's my litmus test. So much of traumatization is a memory. We are imprinted, and that memory of the experience, as it's impacting us and even going into our bodies, i.e. somaticizing, is what remains. And in that memory is what we draw on when we have something that brings it up, activates it, reminds us of it, or becomes so powerful that it becomes our entire world. That's all we see is this perception of threat, regardless of how kind and compassionate we are to the person. Oftentimes, that's how I like to think when I'm driving on the highway at 5 o'clock on a long weekend on a Friday afternoon, and people are road raging, giving people each other the finger. I think through a trauma-informed approach that oftentimes what we're perceiving or misperceiving in some ways is a sense of threat due to a memory that's been stuck with us from an experience, whether it's lived through or witnessed, that was been somehow traumatizing. And folks, this is an actual statistic from 2008 of the number of Canadians that have experienced at least one traumatizing event in their lives. And I ask you, if we really look at the statistics today, what is the percentage of Canadians that have experienced at least one traumatizing event in their lives? It's got to be 100%. And babies, unborn babies in utero, they can experience traumatization, if not from the external environment. Yeah, Tandy, for sure. From the external environment, then from their own DNA that they've inherited from their parents, right? However, parents are defined. And that is a very high statistic. That means if we have 220 people on this, 221 people on this webinar, 221 of us have experienced at least one traumatizing event. And that's just us who are providing the care, let alone the people that we are serving. So we must have an approach that addresses and supports these aspects. Christine says the sad truth is that there's likely not a single person with whom we be in contact who has not experienced. Exactly, Christine. So where's that perception in our work? Where's that I mean, basically, Christine, what you just said there is a trauma-informed approach, literally. And I'm going to give it away, is the fact that we just assume that everybody, every single person, not just that we care for, but who we actually work with, has experienced some aspects of traumatization. So let's look at some quick trauma outcomes, folks. What I like to understand in this work is that oftentimes when we've experienced some form of traumatization, we have an adaptive response to that threat, to that, even that if it's a perceived threat, it's a threat, right? We have this adaptive response. The challenge with us in our work is that when that adaptive response is applied to situations that don't quite align with the need for the response, it becomes maladaptive. This is what we see in our work, right? If we're, especially in my work, hospice settings, hospice palliative care settings, where we're providing care, compassionate, hopefully person-centered care, although I think you can't provide person-centered care without a trauma-forward, culturally humble approach, then it becomes somewhat, it's a judgmental term, and I apologize for that, but I'm using the literature, a maladaptive model of engagement. So somebody is reacting to kindness and support and love and a safe space as if it's threat, because they're living in a memory of a past, of an experience that has caused traumatization. That it was one time the response was adaptive, but now it's no longer adaptive to what is actually happening. And that can lead to relational mistrust. That's why when the people we serve don't trust us in the care that we're providing for them. I never forget this one individual I was caring for a number of years ago. 30 years he'd been living on the streets of Toronto, right? And he looks at us and he says, I'm not taking your effing medicine. I don't trust what's in that. And he was in extreme pain, but he refused to take the medicine. He used to refuse to take the pain medication that would, alleviate some of his pain. One, it was his own pride and resiliency and sustainability. The other was that he didn't trust us, right? He had that relational mistrust. And the other was the choice and autonomy he had with which to direct his own care. And he died in physical pain, but not necessarily in suffering, because he still had the autonomy piece, which we'll see it's part of the principles of trauma-informed care. And then we get stuck in these survival mechanisms because our threat response is on. And these survival mechanisms have us act out behaviors as if these situations, these people, these experiences are threatening. That's the maladaptation. That's what we see in the people that we care. That's when they come to us and they have these responses, not just sort of outbursts in anger and violence. And no, sometimes it's what we call the good patient, because part of an adaptive response to a threatening situation is actually the fawn phase of fight or flight, fawn and freeze. That fawn phase is when we become very likable, very, very cordial, very, receiving of care, very pleasing. Sometimes, folks, that's a trauma response in and of itself. I'm always mindful of that because, in fact, that's part of my history. And as I mentioned to you before, folks, so much of trauma and traumatization is the perception of threat. So often is that, that's what holds my judgment back, is that I recognize that maybe what this person is seeing and reacting to is not who I am. They're reacting to a perception of it. It's how we perceive a situation can determine if it's traumatizing or not. And then, if you go in really deep into that, our perceptions are built on our DNA, our, however we grew up, our childhood, our experiences and definitions of family, all these factors that build into perception that determine if something is threatening or not. The situation doesn't necessarily determine it. It's our own perception of it that's determined it. And the effects on trauma, folks, are numerous. Take a look at this, right? It literally, trauma and traumatization literally changes our brain. It literally the circuitry in our brain between the thalamus and the cortex and the amygdala change. And so if there's changes in the brain, it's not as if we can actually unchange that overnight. When they talk about think before you act, sometimes we can't think before we act because of the changes to our brain. And I'm not excusing violence on the TTC. If anybody knows what the TTC is, it's transit system in Toronto. But I'm not excusing any of that, but there's a recognition that there's changes to the brain that can't be unchanged in a particular moment. There could be increases of physical, mental, emotional, spiritual stress from trauma. And then you add a dying experience, you add anticipatory loss, you add physical pain, that just ratchets it up, the experience of stress. There can be affect dysregulation, where what we see and how we act is different from how we feel, because those two parts in our brain are separated. They're disconnected. What we're perceiving and how we respond are separate. What we're perceiving and how we feel about it, and then to think about it, are all disconnected. Literally, trauma, in many ways, I think Dr. Bagabo Mate said this. He said, trauma is a disconnection from yourself. Really, you stop being able to rationalize things. There could be dissociation and changes in consciousness to separate us from the pain and the suffering that can be caused by traumatization. There can be even changes of self-perception, like in how we perceive ourselves. So often, folks, I've seen people say to me, I don't deserve this, or I'm damaged, or I'm wounded, or this is not something that I can actually receive in terms of care, because their self-perception has been affected by traumatization. And that can lead to disturbance in relationships, not necessarily between chosen family and found family, which is possible, but between our relationships with them, right? Because there's a lack of trust. There could be aspects of somatization. I guess that was so important that we put it twice. You can see that. And what is somatization? Is when the experience inhabits the body. The great Roshi Joan Halifax, if anybody ever heard of her, she says, are they inhabiting you? Meaning, are these traumatizing experiences living within our bodies? And that can cause alterations in systems of meaning. What is alterations in systems of meaning? That which was supposed to provide care no longer is perceived as safe and trustworthy in the care that is provided, because we're coming from a feeling and a place of threat. That leads to possibly decreased trust in the medicine we provide, in the interventions, in the care, even in who and what we are. And then that also can lead to attachment difficulties. There's always a little bit of attachment, or maybe I shouldn't say always. There's often a little bit of attachment in how we care and provide for people. But if there's that backdrop of threat as a result of a traumatizing experience or experiences, then it's very difficult to feel safe receiving care and attaching to people that provide the care, because we result in this hyper arousal. So often in traumatization, we see that hyper arousal. The anger, the outburst, the fear, the uncontrollable anxiety, okay, and all the gradations and continuum of that. Or we see and often miss is hypoarousal, where somebody looks bored, disengaged, right, nonchalant. But that could be also a form of an experience of traumatization, where the nervous system goes high or goes very, very low. And that is oftentimes what we see, folks, as rigid or chaotic behavior. I never forget this one individual who came to us, and literally for the first 2 hours, myself and the nurse just move my bed here, move my bed here, move my bed here, move my bed here, move my bed here. And she came from an upper middle class, affluent neighborhood, had lots of money, never even looked at in some way that I mean, for me, it did in some way. I started to look at what is this behavior in terms of why is she moving her bed all over the place. And finally, she got her bed in the corner. And I gently asked her, I said, oh, what's with the bed in the corner? How do you feel about that? She looks at me and she goes, because I can see you two coming. I was like, oh, she says, 2 walls are blocked off and I have 2 walls to see you. So when I talked to her and had the privilege of sitting in time with her, It's not because of her necessarily her experiences of trauma. Her husband was survived the Holocaust. So he had experienced a lot of traumatization. And by association and living with him for 50, 60, 70 years, she had experienced his experiences of traumatization, yet she had never experienced directly. And so this feeling of safety, which she was trying to create with us, wasn't completely apparent. Trauma is so interesting, folks. Some of the aspects, I see your question, Nathaniel. I'll definitely get to it in a little bit, please, by all means. Some of the tension reducing behaviors, folks, is, for example, this picture, right? As you know, it's called cutting. And there's different ways to look at and perceive it, but we also have aspects of substance use. 80 to 90% of substance use or problematic substance use, or maybe even not problematic, or chaotic substance use, is to cope and manage traumatization. I mean, what does alcohol do but depress our nervous system? And if our nervous system is activated and you use alcohol to depress it and bring it down, what's that? That's a form of a coping mechanism. There could be aspects of suicidality. This was my out in childhood, was suicidality. It wasn't the fact that I was depressed and I wanted necessarily to end my life, but I wanted to take the autonomy and control of my own life and say, I got my own control on this. And we have aspects of hypersexuality, however that's perceived in terms of connectivity. We have, eating, right? However, overeating or undereating in terms of that control and autonomy. We have even spending sprees and how we spend our money. I think part of the spending that happened during COVID-19 was because of the experience of traumatization of the pandemic. And then I was corrected once. I was teaching this session a number of years ago in Hospice Niagara, and I was corrected by a PSW in the back. She goes, "Excuse me, sir." She called me sir. I'll never forget that. I'm like, just call me Rami. And she said, "I don't believe it's self-harm." And she showed me her arms. She said, "I don't believe it's self-harm. I believe it's self-preservation, because without cutting, I'd be dead." So it was her way to manage her experiences of traumatization. So what is a trauma-informed approach? How do we apply a trauma-informed approach? And this is it, folks. It's so simple. Somebody mentioned it before. I think it was you, Christine, although there might be a number of Christines on the call today. Simply assume that every client, resident, patient that we care for has experienced some form of traumatization. And if I can take that a step further, folks, assume every single one of you, everybody you work with and engage with, has experienced some form of traumatization. That in and of itself, I feel, is a pillar within what Dr. Carl Rogers called the unconditional positive regard. If you can assume that, you're halfway to compassion. And we don't necessarily need to ask people about their experiences with traumatization, especially in hospice palliative care. I'm not a therapist. I never delve into people's experiences with traumatization. I just recognize what are the behaviors and expressions that can imply an experience of trauma or an experiences of traumatization, and then apply the principles that I'm about to share with you. And this is it. These are the principles of trauma-informed care. We look at, where is the sense of control? Who has control? How do we afford control? How do we permission control within a care setting? Literally right down to what food they eat, what medicine they take. Can they not take pain medication if they don't want it? How much control within the boundaries of our role can we afford? And can we provide care and recognize that they don't necessarily have to trust us, and recognize the lack of trustworthiness as an experience of traumatization as we're providing care? I find we struggle a lot with that in hospice, especially. We have these lovely buildings and people come and they die in our beds, and we're sometimes supposed to, feel like they're supposed to trust us because we are this compassionate people that are providing care. But it's not necessarily the case, because the perception of trauma and threat lends itself to a lack of trust, because there's a lack of feeling of safety. And who has choice? I think a lot of the medical assisted dying movement, folks, was about choice. And maybe some of it was steeped in our life experiences of traumatization, that we feel we don't have choice, and we're trying to execute and exercise choice in some regard. That's why we focus so hard, I hope, in hospice palliative care on the expressions of choice, because it could be a place where trauma lives, where we don't feel we have choice, we don't feel we have trust, we don't feel we have control. And then who defines safety? So often we call places a safe place, but how can we do that? We can intend safety, but who defines safety? If the perception of traumatization lies in the person, then they define what's safe for them. And so often when I sit with people and I care for people and I talk to people in this broad spectrum of caregiver role, caregiving, bereavement, end of life, children's grief, I often inquire, what is their idea of safety? How would they feel safe? Where they do not feel safe? And it's amazing what they surface for us, because it's a lot of the places and things that we do that we assume are safe that aren't necessarily safe. And that leads us to an experience of empowerment. Who sits in empowerment? Who has that power? You can never empower somebody. They have to step in there and into their own empowerment if they so choose. We just create the environment and the opportunities and the engagements which they can step into their own sense of power. And do we recognize trauma robs people of power? They don't feel they have that power. So what they do, they become sometimes in this perception of malaligning or manipulative or aggressive, when it's all a desire to gain power. And then if we recognize, folks, through a culturally humble approach, that we all have our individual personal culture that is influenced by the myriad of influences in the world. And we're not talking about Instagram influences, all right? We're talking about the influences of the experiences of life and traumatization. Then we develop this idea of a personal culture within the context of however we define culture, right? In food and ethnicity and all that kind of stuff, right? If you can pull all these together, folks, then you can start talking about compassion. But what is compassion? Compassion is communication, passion, which is pathos, which is feeling in Greek, is when we can feel for another. And if we feel for another, it's exactly what June Caldwell did to me 35 years ago. She felt for me. She saw where I might be in, an experience of a lack of control or a lack of trust or a feeling of disempowerment, even in the way I held my body, or where do I feel safe, or what choices do I really want? Literally, that's compassion. And if we can pull these trauma-informed processes, then we can start talking about compassion. Because I think oftentimes compassion is inauthentic in the care we do. How can it be compassionate when we don't receive from the person and identify and acknowledge all these aspects of traumatization? I want to share some quick definitions for you folks. Cultural safety, these are definitions from an amazing organization. A colleague of mine works for them out in BC, called the First Nations Health Authority. And they have a whole program and a whole website called Creating a Climate for Change, hashtag It Starts With Us. And they have the best definitions of culture safety and culture humility. You want to learn more about culture safety and culture humility from a trauma-informed approach, please check out their website. They say culture safety is outcome-based on respectful engagement that recognizes and strives to address power imbalances inherent in healthcare systems. It results in an environment hopefully free of racism and discrimination, where people can feel safe when they are receiving healthcare. Do you recognize the trauma-informed principles in there? Power, safety, right? Those are aspects of trauma-informed. And even in my mind, what I really resonate with is their definition of culture humility. Culture humility is a process of self-reflection to understand personal and systemic biases and to develop and maintain respectful processes and relationships based on mutual trust. Cultural humility involves humbly acknowledging oneself as a learner when it comes to understanding another's experience. Now, take a look at that, folks. Culture humility, as it intersects with trauma-informed care, is self-reflective. And that's why it's so hard. It's so simple, but so hard, because it takes the whole aspect of self-accountability. Respectfully, we can't leave it on organizations to catch up to us individually learning culture humility and learning trauma-informed principles. I try really hard. I do a lot of education and training in culture humility and trauma-informed principles within organizations from the inside for the staff and volunteers and leadership, so that it grows into the culture of the organization. But it really starts with us individually, self-reflecting, to look at our own biases, our own personal biases. See how the First Nation Health Authority doesn't dismiss the personal biases that we all carry, but integrates it into the systemic biases. And that's the systemic biases is where a lot of traumatization happens. But what they also say, it says culture humility involves humbling, acknowledging oneself as a learner. And that's the bread and butter for me, folks, is humbling, acknowledging oneself as a learner to somebody's personal culture as it's infused with trauma and traumatization, and as it's expressed and acknowledged as such. That's why those principles are so important. Because right now, folks, we are literally in the world, if not in healthcare, let's focus on healthcare. I don't want to get too big, right? In Canada, right? That's big enough, right? I love this country, but we have a lot of experiences of traumatization. We're literally at a crossroads, right? In healthcare, but especially for me in hospice palliative care. And that crossroads is in the more accessible and inclusive we try to be, the more we have to be mindful of the implications and effects of traumatization or people who have experienced traumatization. And if it's not enough for us to think that every single one of us, the people we serve and the people that provide this service has experienced traumatization, let's at least focus on that 76% that we have researched to say that there's a majority of people that we provide support for that have experienced traumatization. And let's look at how we can integrate these principles, because each one of those principles, folks, I can respectively speak to you for an hour on every one of those principles. How do we incorporate those principles? And I will share resources with Pallium that you can do your own education, your own learning, within organizations, within yourselves, of how to grow a trauma-informed approach within your specific line of work, right? Within your specific caregiving role. Because if we can do that, the bigger and more accessible our work gets, the greater the diversity of peoples that come, the more it demands from us as care providers to provide a model of engagement with which not only does it, protect the people we serve, but protects us. When we talk about self-care, folks, how can we talk about self-care if we're not talking about trauma-informed principles applied to us? Take those principles and see, how do we feel when we don't feel like we're in a situation where we don't feel we have choice? How do we feel when we've experienced an aspect of traumatization that's projected, if not infusing the work that we do, where we don't feel, a sense of trust, or we don't feel a sense of empowerment, or we don't feel a sense of choice? This stuff about leave yourself at the door and step into somebody's room is impossible. We bring our entire selves in there. And part of that self is that experience of traumatization that's often infused into our personal culture. Folks, I have to tell you, like, naturalizing or normalizing and validating someone who has experienced trauma can be one of the most powerful interventions that we as volunteers and staff can make. It's called trauma glasses on, trauma glasses off. And I learned this from esteemed colleagues in the field. It's not mine. That when I put my trauma glasses on, I'm trying to see through those principles of trauma-informed care and apply them in every circumstance that I am in. And just for a teaser, I'm not going to go through this for. I left this in the PowerPoint presentation for you to digest and go through on your own. You're going to have this presentation. You're going to have a PDF of this. Check this out. Work with this with your teams. It's an actual personal account of an experience of somebody who has multiple experiences of traumatization. See what you see. See how you can work with it. See what where it arises for you, resonate with it, or even a bias towards it. You can work with it within your teams, or you can work with it individually. I think it's a great starting point with which to have this personal account, i.e. a case study. I don't like that term. And apply the trauma-informed principles. And if you so do, you might come to these summary in the end, where somebody's trying to get ways met that have worked for them in the past. Remember the maladaptive, adaptive responses? Maybe somebody feels threatened, unsafe, out of control, fearful of being re-traumatized, and that's what's fueling their behavior. Oftentimes in hospice palliative care, we pride ourselves of having a comfortable, safe environment, but maybe it's out of somebody's comfort zone, and the unfamiliarity of that comfort zone lends itself to an exacerbation of their experiences of trauma. Maybe the fight or flight response is on high alert, and they feel alone and overwhelmed, even though they have lots of people around them. And so common, folks, is that mistrust and afraid to make progress with any one of us for a fear of losing us as well. Right? That's the mistrust. That's the lack of trustworthiness that's often caused by traumatization. Finally, folks, I want to leave this with you. This is my pride and joy. It's not mine. I shouldn't say it's mine, because it's an ancient Japanese healing practice. I'm not sure if anybody recognizes what this is. This is kintsugi. Man, Japanese heritage, Japanese ritual had it right back in the 15th century, although trauma has been with us since whenever we came to be. This is actually my bowl, folks. Whatever I often ask, I wish we had a little bit more time. I often ask what people see in this bowl. And oftentimes they say, oh, I see the gold lines. I see it's been broken. I see that it has pieces missing. I see that there's pieces been repaired. But then I also ask, can you see that it's sitting on a placemat? Can you see that it's a gray background? Can you see the blue cloud? Can you see the green mat? Can you see the entire picture as June Caldwell saw me? Because that's my life. That's me. That's my experiences of childhood developmental trauma. I broke that and I put it back together. The idea behind kintsugi is that that which was once broken can be healed and not necessarily made more beautiful, but made more aware of our life experiences. So I broke that bowl and I put it back together. There's pieces missing. There was pieces that couldn't fit in there. There's pieces that I didn't want anymore in there. All symbolic of people, jobs, and relationships. And then I painted the lines in gold, not for make it look beautiful, but so that I can see it. That's a self-reflective process that the First Nation Health Authority is saying when they talk about cultural humility. Can you look at yourself and see your biases and see your experiences of traumatization and see who and what brought you to this particular moment in time and day? And above and beyond all that, can you still see the person, the blue, the gold? And you flip it over, it says, made in China, and it's an IKEA bowl. Can you still see all that? And that's our job, folks. That's our job, to see the entirety of the person, and entirety of us, and entirety of the people that we serve, and however it's presented, because that's the bowl I serve with, right? I can't leave all the experiences of that bowl behind at the door. That's the bowl I serve with. Because technically, folks, we're a bunch of broken bowls serving a bunch of other broken bowls in some measure of repair. And I like to keep that perspective, and it keeps me humble, and it keeps me in an alignment with, hopefully, a compassionate state. One final thing, folks, we have this podcast for Lighthouse Forgiving Children. It's this is the amazing Andrea Warnick. I've had a number of people in there. We've had over 1,000 downloads. It's all children's grief through a trauma-informed approach, a culturally humble approach, and a diversity lens. And I think that's enough. I've given you enough. Your final points, you could read them. And I just want to bring it to a close, folks. If you have any questions, please don't hesitate to send me an email. Diana and Aliyah have my email. I'm happy to answer all those questions in fulsome through an email. Send me an email and I can definitely provide those resources. So thank you. And then if we have a moment, I just want to answer Nathaniel's question. Okay. How do you balance the awareness of traumatizing effects perception with the need to be reflective and to acknowledge when we do enable harm within institutions? Nathaniel, please, if I can send you an email to that response, I'd love to. That's more than just a 5-second response, but that is an exceptional question, because unfortunately, there's still a lot of harm within institutions in the perception of kindness and care.
Fantastic. Thank you so much, Rami, for this such relevant, relatable. I have so many adjectives for this entire presentation. It was absolutely wonderful. I'd like to also let everybody know that there has been a feedback survey that has been thrown into the chat. We'd love to hear what you think. We do have Joan Pham in the question in the Q&A, who's saying, this is my question: do you have resources for healthcare providers working in this field with direct or vicarious trauma and ongoing grief? And of course, we can add those right into the follow-up email that we're going to send.
Absolutely. I'd be more than happy, Joan. I'm going to send a fulsome resource list of programs, websites, books, you name it, to Diana and Aliyah. Not a problem at all.
Fantastic. Once again, I'd like to thank everybody for taking the time to join us today. We love having you, and thank you so much to our presenter, Rami. It has been a wonderful pleasure to have you with us today. Thank you.
Thank you.